We would start the first lecture from the ELSA 2019 Congress President. First, I would like to thank Professor Mori for his wonderful task and his excellency in switching from the meeting to be online as a virtual with the beautiful Congress, the program. So let me start with the talk. Professor Yuki Mori is the president of surgery of Kyogen University, chief of ESSQS, GI, and general surgery. Please welcome Professor Mori for his talk.
My topic this morning is assessing the surgeon's proficiency and its impact on clinical outcomes. I do not have a COI to disclose. Surgical skill, operative maneuver, is essentially a perceptual motor skill. Surgeon's proficiency is not accurately defined to date. Largest part of surgeon's proficiency is, of course, surgical skill. The operative maneuver is essentially the perceptual motor skills. Perceptual motor skills initially refer to a child's developing ability to interact with his environment and combining the use of senses and the motor skills. Operative maneuver is essentially the same. You observe the surgical field, you understand what is going on, and you decide what to do, and motor execution is followed. And this loop is repeated over and over again. The proficiency of surgeons are evaluated using surrogate variables or proxies. Most often the way surgical proficiency is evaluated using surgical simulators. ESSOC reported a good review about it. And another approach includes clinical observation. Most representative one is OSATs. And interestingly, surgical volume is a proxy of the surgeon's proficiency. Surgeons experience more, the less experience the complications. But these former studies has problems. First, these studies are often irrelevant to clinical outcomes. And second, often subjects are surgical residents. So they are focusing too much on learning curve. And of course, implicit knowledge of the institution is an important part of surgeon's proficiency, but these studies are ignoring the implicit knowledge. Surgeon's proficiency has many phases. So comprehensive assessment of proficiency is needed, and it should be discussed in relation to clinical outcomes. The interesting report is out from Michigan Bariatric Surgery Collaborative. They are rating the video of the participating surgeons. The bottom rate is 2 and the highest rate is 5. And in bottom quartile surgeons experiences more complications, and top guns experience like a 5% of complication. Blue cam indicate the bottom quartile surgeons. The rate of complication is as high as 15% in bottom quartile surgeons. In contrast, the top guns expressed in brown column experienced like a 5% complication rate. And reoperation rate, readmission rate, and revisit of emergency department is also high in bottom quartile surgeons. And it is the smallest in the quartile of top guns. As you see in this slide, we have experienced the dip in the number of laparoscopic surgery in between 2001 and 2005. The cause of which is many lawsuit cases filed to accuse surgeons' inability to perform laparoscopic surgery. The most famous case was GK incident happened in 2001. the first case of laparoscopic total prostatectomy for 3 board-certified urologists in a university setting. Duration of operation was 11 hours. These urologists were eventually accused and sentenced 3 years in jail for insufficient skill to start new procedures. We just started discussing about endoscopic surgical skill qualification system, ESSQS. And in this system, unedited video record is judged by the 2 blinded and independent referees by the predetermined score sheet. In GI and general surgery, we have some specialties including esophagus, stomach, colon, and so on. And we designed this system. Each of the subspecialties can grant the ESSQS. In GI and general surgery, we prepared the common criteria and procedure-specific criteria. Common criteria includes implicit knowledge of the institutions and setup, and manual dexterity is just a small part. And procedure-specific criteria is designed to evaluate the completeness of the steps in the procedures. This slide indicates the number of applicants and the qualification rate. Blue lines indicate the number of applicants. Today, we have more than 700 applicants per year. The qualification rate is as low as 25% today. This slide picks up the qualification rate in each subspecialties by year. Qualification rate in each category was as high as 40–50% in the very beginning, but it is now 24% in colon group. Who qualifies the ESSQS? The mode year age of the qualified surgeons are 41. So you need 10 years of clinical practice after the residency. This slide compares the short-term outcomes of qualified and non-qualified surgeons. Skilled qualified surgeons outperform failed surgeons in terms of complication rate, duration of operation, estimated blood loss, and post-operative post-hospital stay. But study is based on a questionnaire, and patient background is not noted, and definition of complication is ambiguous. So we started thinking about the NCD ESSQ study. NCD is a clinical database started 2001 in Japan. Over the 95% of surgical case is recorded. It is like a ACS, National Surgery Quality Improvement Program. And we can evaluate the attendance of ESSQS surgeons by looking up the medical record registration numbers. Basic question here is, does participation of ESSQS surgeon really improve the short-term outcome? We first extract the lap chole for acute cholecystitis. More than 600,000 of laparoscopic cholecystectomy were done in the study period of 2016 to 2018. And we extract only the cases with a diagnosis of acute cholecystitis, and the resulting cohort is 65,000. Then we extract the operation attended by ESSQS biliary surgeons, and then ESSQS stomach surgeons, and then ESSQS colon surgeons. The rest of the cohort is regarded non-skill qualified attended cases. This slide compares the background of skill qualified surgeons and non-skill qualified surgeons attended groups. Female-male ratio and age category is comparable in both groups. And the ASAPS is identical in both groups, and emergency surgeon rate is comparable in both groups. This slide shows result in lap quality. If the lap quality is attended by skilled qualified surgeons, the rate of death in 30 days is just 0.1%. But the surgery is attended by non-skilled qualified surgeons. Death in 30 days is 0.3%, and this is statistically more than in SQ group. This result is true in 90-day death and estimated blood loss and post-operative hospital stay. And biliary qualified surgeons, stomach qualified surgeons, colon surgeon qualified surgeons displays incomparable result. And all these groups better than in non-SQ group. In right hemicolectomy and low anterior resection, results are somewhat different. Skilled qualified surgeons and non-skilled qualified surgeons are comparable in terms of surgical mortality and anastomotic leakage rate. And in low anterior resection, only leakage rate was better in colon qualified surgeons, but surgical mortality were comparable in all groups. Distal gastrectomy and total gastrectomy result is totally different. Or even in distal gastrectomy, stomach qualified surgeons outperform others, and anastomotic leakage rate is better in stomach qualified surgeons. In total gastrectomy, the difference is more evident. Stomach qualified surgeons outperform the colon biliary qualified surgeons and non-qualified surgeons in terms of surgical mortality and anastomotic leakage rate. This slide shows summary of NCD ESSQS study. In lap quality, surgical mortality is about 1/3 if surgery is attended by SQ surgeons. In colonic surgery, the attendance of skilled qualified surgeons is not evident. And in gastrectomy, even in distal or the total, qualified surgeons are statistically better both in terms of surgical mortality and the rate of complications, anastomotic leakage. This slide shows lessons learned. 1. Endoscopic surgical proficiency can be subjectively assessed by ESSQS. And impact of SQ surgeons vary in fields. If you suffer from lap quality by acute cholecystitis, you'd better ask SQ surgeons because mortality is 1/3. And if you suffer from gastric cancer, also you'd better ask the skilled qualified surgeons. Merit of proficiency surgeons may vary depending on procedure specificity and its complexity. In conclusion, surgeons' proficiency can be subjectively assessed, and surgeons' proficiency impact surgical outcomes more in complex and demanding procedures. Thank you for your attention.
Thank you very much, Professor Mori, for the excellent talk on proficiency. You have shown us a very nice system. So before we finish this session, could you please give us a last talk for the conclusion for everyone in ELSA or our friends for the proficiency evaluation that you may suggest for any society to be adopted?
Actually, the evaluating the surgical proficiency is a big problem for the surgical society. Maybe to keep the surgery safe, and maybe for the resident education. So to set the goal of education and to set the line of achievement, we need to assess the proficiency of surgeons for sure, I believe.
Thank you very much, Professor Mori. I think the first session that we have started with ELSA 2020, leading by you and your team, it's excellent. So it's a wonderful start. So congratulations and thank you very much.
Thank you very much.